Thank you to the organisers for inviting me to speak on glaucoma tubes and the corneal endothelium. As I mentioned in previous talks, I work with a number of companies and specifically with Advanced Ophthalmic Innovations, the manufacturer of the Pole glaucoma implant. Many corneal specialists will say that tubes cause corneal decompensation. Most studies don't demonstrate this clearly. Partly probably because most tubes don't cause corneal decompensation inside the 5-year duration of the longest prospective studies. Very long-term studies do exist in the past, but in general have not reported the rates of corneal failure. Most corneal specialists say this because they only see the ones that fail. And from a glaucoma specialist point of view, it's obviously easier to replace the cornea than to replace the optic nerve. This graph is from the publication of the original follow-up study of the AMID glaucoma valve, and it shows fairly reasonable success rates after 4 years if corneal failures are excluded. If corneal failures are included, the success rate is rather lower, and you can see there's quite a dramatic difference in these two graphs. Having said that, this study did contain a preponderance of patients with corneal disease, so it was not so surprising to get so many corneal failures. Clearly, if you have a tube that's right up against the cornea, that's not going to be good for endothelium, and that's not rocket science, but again, this is not what we're dealing with most of the time when we're worried about the endothelium. It's also worth noting that long tubes for a long time have been blamed for corneal problems, and this is probably not without some substance, because as you can see here, with a bit of eye rubbing, you can make the tube move all over the place. And in this eye in particular, I was able to make it touch both iris and cornea, depending on whereabouts I depressed sclera over the eyelid, simply massaging or rubbing the eye. And you can see how it's touching the cornea. If you move slightly further forward, it touches the iris. If you move further back, it touches the cornea. So eye rubbers must clearly be at risk. Ideally, a tube in the anterior chamber should be parallel to the iris plane and ideally just in front of the iris. This one does enter quite posteriorly close to iris, but is pointing forward towards the cornea, so the tip is almost touching the cornea. And this is one of the reasons that long tubes get blamed for corneal damage. It's actually because often, traditionally, they were angled forward, so that the longer they were, the closer the tip to the cornea. But tube length is really only one of the many potential risk factors, and for a long time I've been interested in the influence of the tube entry site and whether that has an effect. I was always convinced that if the tube was flat against the iris and not touching endothelium, then the cornea might be much safer. And here's a tube entry that is perhaps not far from what many people do. There's scleral spur. So you can see the tube really is quite anterior, and what looks like a nice position, this really isn't peripheral cornea. Does that matter? This is the question. Well, we conducted a prospective study that I'm going to describe to you. This was presented at the American Glaucoma Society in Washington 2020 and subsequently published. I've described some of the background already. There is ample evidence that shunts reduce corneal endothelial cell counts, and surgeons often focus on tube length, whereas logically entry site position might be just as important. Other factors such as pressure, inflammation, and pre-op endothelial cell count are also important potential risk factors. So the purpose of this was to study prospectively the influence of the above factors on both peripheral and central corneal endothelial cell count at 5 years after a Barvelt implant. We recruited consecutive patients from my firm undergoing a Barvelt between September 2011 and October 2013. We excluded anyone with a history of corneal disease, a previous implant of any sort, A bar vault in the sulcus or pars plana, as the numbers weren't enough for meaningful comparison. Congenital or secondary glaucomas that might affect the cornea, and patients who declined to participate. All of the clinical history and examination always performed by one experienced examiner, Scott Howe. And preoperatively and postoperatively at 6 months and then annually for 5 years, we measured IOP, number of IOP lowering medications, complications, gonioscopy, aqueous flare, anterior segment OCT tube position, and endothelial specular microscopy. All patients were implanted in the supratemporal quadrant with a bar vault 101-350 with 5-minute exposure of 0.4 milligrams per ml of mitomycin on a couple of sponges. All tubes were occluded with a supramid to prevent hypotony, with variable numbers of tenonylon ligatures as required according to the visible flow at the time of surgery. Each tube was patched with an appropriate donor patch graft, conjugate closed with tenonylon. And this is the rough setup. A gonioscopy is performed before and after surgery in order to document the degree of PAS in clock hours, but more importantly to record the position of the tube entry site in the drainage angle according to the following classification. And tip stands for tube insertion position. Tip 1, all of the tube behind Schwalbe's line. Tip 2, some of the tube but less than 50% anterior to Schwalbe's line. Tip 3, most of the tube anterior to Schwalbe's line, i.e. straddling it. And tip 4, the whole tube in the cornea. And this, for instance, would be classified really as tip 4, as pretty much all of it's in front of Schwalbe's line. As previously mentioned, all patients underwent anterior segment imaging using the Visante in order to image the tube. After some standardization, the tube was imaged using anterior segment high resolution scanning mode with the patient looking down so that the axis of the tube was aligned longitudinally with the Visante, and so that both intrascleral and intracameral tube portions of the tube could be clearly seen. The top right shows the parameters that were measured, and listed the bottom right of the slide are the actual parameters spelled out in full. Corneal endothelial specular microscopy was measured using the Topcon SP2000 system. The images were obtained automatically for the central endothelium, but peripheral images were obtained manually. And we looked at endothelial cell density, hexagonality, and coefficient of variation in cell size. This method of analysis has previously been published in 2000 in Current Eye Research. So 77 patients were eligible and 64 completed the study, and the dropout is shown here. There were no surgical complications. Postoperatively, 1 hyphema, 1 diplopia, 6 hypotony, of whom 2 were revised within 6 months surgery. And there were a few postoperative procedures such as 1 membranectomy, 1 exposure, 1 CyPass for additional pressure lowering, and 1 hypotony at 3 years requiring revision. As you can see from the baseline demographics, half of the patients were uveitic, 40% POAG, and the rest were a smattering of secondary glaucomas. The highest recorded pressure was mean 38 millimeters of mercury, mean of the last 3 IOPs before surgery, 24 millimeters of mercury on 3.2 medications. If you break them down into the uveitics versus the POAG, you can see the only statistically significant differences were of highest recorded IOP, which was higher in uveitics, number of medications, the higher in uveitics, amount of PAS was higher in uveitics, flare was higher in uveitics, not surprisingly, and baseline corneal thickness was actually slightly lower in uveitics. The other corneal parameters apart from central corneal thickness were all the same. And here are the results. You can see the pattern. Central endothelial cell density down 37% almost at 5 years. Peripheral down 50% at 5 years. On univariate analysis, central and peripheral endothelial cell density were highly significantly reduced, whereas coefficient of variation and hexagonality were not. The factors associated with these reductions appeared to be the tube entry site straddling Schwalbe's line both for central and peripheral endothelial cell loss, and also tube length and tube angle to the iris. On multiple linear regression analysis of central corneal endothelial cell density, the tube insertion position was associated with lower CCED at 5 years, and specifically the tube tip straddling Schwalbe's line. So if all of the tube was behind Schwalbe's line, there was 24.7% loss. Some of the tube, but less than 50% anterior to Schwalbe's line, slightly higher loss, 32%. Tube entry site straddling Schwalbe's line, 48.9% loss. Surprisingly, tube entry site in the cornea was actually quite a bit less than tube straddling Schwalbe's line. And repeated measure analysis also shows significant difference across all time points. Significant interaction over time with tube entry site position as well. And peripheral endothelial cell density showed exactly the same thing. Tip 3 was associated with the worst endothelial cell loss. Tube length was associated with lower PCED, as mentioned before, but shorter was worse, not longer. Repeated measure analysis, again, significant interaction between tube entry site and change in peripheral endothelial cell count with time. Significant interaction over time with tube entry site position. So in conclusion, multivariate analysis shows quite a dramatic reduction in both peripheral and central endothelial cell count at 5 years. That is very much associated with tube entry site position. If the tube insertion position is behind Schwalbe's line, there's roughly 25% loss of central endothelial cell density in 5 years. If it's straddling Schwalbe's line, that's actually worse than even being in the cornea, with almost 50% loss. Flare, pressure, and uveitis did not seem to influence central endothelial cell density. Only one eye developed corneal decompensation in 5 years, and this was published in Ophthalmology Glaucoma last year. Interestingly, the same month, there was a publication in Ophthalmology looking at amide valves, and they measured the endothelial cell count pre-op and post-op, and they found tube in the sulcus showed less endothelial cell loss than tube in the AC. However, it's interesting that the endothelial cell loss that they found in the sulcus was still fairly significant, was actually slightly higher than what we measured in tubes behind Schwalbe's line. So it seems as if tube behind Schwalbe's line, tube in the sulcus, doesn't make much difference to endothelial cell loss. And the take-home message really is, yes, the tip's important, but the entry site should never be in peripheral cornea. So here's a patient with a Barvelt and a clear cornea. This Barvelt was implanted in 2007. The video was 12 years after implantation. And this eye, 17 years after implantation. Both have clear corneas, so the adage that tubes all destroy the cornea is clearly not correct. It is possible to have a tube 17 years later with clear cornea. Barvelt glaucoma implant is still the most effective IOP lowering implant available, but it is very large. The huge Barvelt contrasts dramatically with the MIGS trend towards much smaller subconjunctival tubes such as the Zen and the PreserFlow. The Barvelt plate is large for very good reason, as this is responsible for the high long-term efficacy level. But at 640 microns in diameter, like the amide valve, the tube is much larger than required. The 640 micron Barvelt and amide valve tubes occupy almost the entire drainage angle and must rest on iris to avoid cornea. Such tubes are in contact with cornea at their entry site, sometimes even when lying flat on the iris. And we know that tube contact with corneal endothelium at the entry site kills endothelial cells. At this point, I'm going to promote the Paul glaucoma implant because it does have a smaller tube than conventional implants, but similar plate characteristics. The tube portion is not very much larger than a PreserFlow, as you can see here. And you can see the difference in external diameter and lumen size that potentially might be less traumatic to corneal endothelium than conventional implants simply because it's smaller. Thank you very much for your attention.